Hello, we are going to talk about treating sleep disorders. It's a cute little slide. Thank God for my PMHNP. A couple of test questions you can take a look at, and here are some resource books that you could consider. So, assessing sleep disorders in the context of treating mental illness is very important. Um, So there are 8 categories of sleep disorders, and within there have been 85 sleep disorders identified. It's important to get a sleep-wake history, looking at the entire 24-hour cycle. So I will ask clients, how are you sleeping? Particularly on a first interview, I will ask them, do you have any trouble falling asleep? And if they say yes, I will want to know, well, how long does it take you to fall asleep? And then I will ask them if once they're asleep, do they stay asleep? And if they say they have awakenings, I will ask, well, how frequently? And after you've awakened, are you able to get back to sleep? And in addition, I would like to know, are they awakening too early and then can't go back to sleep? Do they have trouble waking up on time? And if they have problems with daytime sleepiness. So the client who tells you they're tired all the time, it's important to know what's happening with their sleep at night and also to find out if they're napping during the day and for how long. If you can talk to a parent, that's very useful, or the client's bed partner as well. And sleep diaries can be used. I believe there's a Fitbit that also records sleep quality or quantity. So some of the sleep disorders include parasomnia, such as sleepwalking at night, restless leg syndrome, periodic limb movement, hypersomnia, narcolepsy, along with the comorbid mental illness and or physical illness, such as chronic pain or other types of chronic illnesses. Very important to assess sleep apnea in your clients, because if they do have sleep apnea and you're treating them for depression, or if you're trying to help them sleep, you're going to really be having a difficult time and spinning your wheels if you do not consider the possibility of sleep apnea and send them to get treatment if you suspect it. The stop bang is a simple assessment that I've done, and I've often sent that over to the sleep clinic. So snoring, are they tired during the day? Tired on awakening, also headache on awakening is not unusual. Has apnea been observed? What's their blood pressure like? Their BMI, the age over 50 is significant, and also male, and neck circumference of 17 or greater, 17 inches. So like other mental illness we have studied, we would say there is an arousal spectrum of sleep and wakefulness. So it's really not completely black and white. It's not that just that you're awake or asleep. It's almost like being on a dimmer switch with different phases along the entire spectrum. And where on the spectrum you are is influenced by 5 key neurotransmitters. Those are histamine, dopamine, norepinephrine, serotonin, and acetylcholine. When there's a good balance between too much and too little arousal, one is awake and alert and able to function well. As the dial shifts to the right, there's too much arousal, and that can cause hypervigilance, insomnia at night, and if the arousal and sleeplessness continues to increase, that can cause cognitive dysfunction, panic, and in extreme cases, even hallucinations. So it becomes a vicious cycle if you don't treat the insomnia. There's a good chance that the depression or anxiety will begin or worsen, increase in weight, increase in inflammation, increased cytokines, increased depression and anxiety, and then that cycle repeats itself. Here we're looking at the sleep cycles. There are 5 stages. We call it sleep architecture. From stage 1, which is very light sleep, going into stage 2, which is a deeper sleep where the breathing and the heart rate slows, body temperature starts to cool. In stage 3, we have the deep sleep beginning, and the brain is generating the slow delta waves. And then stage 4, we're looking at very deep sleep. And finally, stage 5 includes REM sleep, rapid eye movement, where the brain waves speed up and the dreaming occurs. Some of our medicines decrease and or eliminate the REM sleep. So the neurobiology of sleep, we're talking about a few different anatomical areas. The first is the hypothalamus. Within the hypothalamus, we have the TMN, which is the tuberomammillary nucleus. This is the wake promoter. It gets you awake. And histamine is a player here. Then we have the ventrolateral preoptic nucleus. This is the VLPO. And so this is the sleep promoter, and the switch turns off. Melatonin is involved in this area. Next, we have orexin or hypocretin. This is involved in wakefulness. Orexin is a neurotransmitter, and it is critically involved in 2 of our newer medicines that are able to somehow turn the orexin off, which allows the person to go to sleep. And if you don't have the right amount of orexin, that may result in narcolepsy. We also have something called the suprachiasmatic nucleus. This has to do with our internal clock and management of the circadian rhythm, which is programmed by the light-dark cycle and melatonin. So different factors affect the circadian rhythm, but light is the most powerful synchronizer. So when light enters the eye, it is translated via the retinohypothalamic tract to the suprachiasmatic nucleus, which is within the hypothalamus. The suprachiasmatic nucleus then signals the pineal gland to turn off melatonin production. And so during darkness, there is no output from the RHT tract to the SCN within the hypothalamus. Then when darkness occurs, and there's the picture right there, when darkness occurs, so here we have the moon up, the darkness signals the pineal gland to produce the melatonin, which in turn acts on the SCN to reset the circadian rhythms. So keep in mind that depression in and of itself also alters the release of melatonin. It's possible that depression elevates levels of cortisol, and in turn, cortisol inhibits the production or the release of melatonin. There's a timeline on the left bottom of the slide. I'm not sure it makes a great deal of sense. It's trying to show phase delay problem with sleep. So one of the drugs we do not have in this country is agomelatine. Dr. Stahl does give a lot of attention to it, but we don't have it available because of potential liver damage. Agomelatine, FYI, is a melatonin agonist, and it may reset the circadian rhythm. Okay, so a little more about what is insomnia. So we're looking at excessive nighttime arousal. Insomnia is conceptualized as being related to hyperarousal at night. And so here the brain is in a red-orange color. So it is overactivated. So the agents that help to reduce the brain activation, for example, the PAMs, positive allosteric modulators of the GABA receptors, so benzos or Z drugs, also histamine 1 antagonists, serotonin 2A, 2C antagonists. All of those can shift the arousal state from being hyperactive to sleep. And now the brain is at rest. We also know that there is insufficient dopamine in the thalamus, so it doesn't efficiently filter, and so that can cause us to be distracted by things around us, and we describe this as having a foggy brain or excessive daytime sleepiness. So with excessive daytime sleepiness, we do not have enough arousal during the day. So we refer to this as daytime hyperarousal. Now we can try to help with that to increase the brain activation using either stimulants, modafinil, or even caffeine, and that can shift the state from being hypoactive to being awake and having a normal alertness. So the hypothalamus is a major control center for sleep and wake. The on switch, the wake promoter, is in the TMN, tuberomammillary nucleus, which is located within the hypothalamus. The off switch is in the VLPO, ventral lateral preoptic nucleus, VLPO. This is the area of sleep promotion. So the two primary neurotransmitters involved here are histamine from the TMN, which promotes wakefulness, and GABA from the VLPO, which promotes sleep. When the sleep switch is off, GABA is released from the VLPO, inhibiting the TMN, and vice versa. When the sleep-wake switch is on, wakefulness is promoted by the release of histamine. Okay, and we're looking at the diagram here of what's happening. So this is the wake promoter functioning. And this triggers the sleep promoter to be flipped on. and the cycle continues. So there are several processes that regulate sleep. The one major one, the circadian wake drive, is due to the input. So it could be light or melatonin or activity that's going to the SCN. And our sleep drive is homeostatic, and the homeostatic sleep drive increases the longer one is awake and decreases the longer we are asleep. So here we're seeing our blue slides with the transporter. In this case, we're looking at histamine and how histamine is produced. So the precursor to histamine is histidine. And the histidine is taken up into the nerve terminals via the transporter. And then there's an enzyme, HDC, histidine decarboxylase, that converts histidine into histamine. And then after it's synthesized, it's packaged into the synaptic vesicles and then stored there until it's released into the synapse. There it goes into the vesicles, and there it's being released. And then how is histamine action terminated? So histamine is broken down by two enzymes. It can be broken down by histamine N-methyltransferase, which converts histamine to N-methylhistamine. That is then broken down by MAO-B to an inactive substance, which is N-methylindoleacetic acid. So NMIAA. There you go. And the histamine becomes inactive. So we have actually H1, H2, and H3. H1 and H2 are postsynaptic. H3, however, is a presynaptic autoreceptor. We also know that histamine can bind to a glutamate receptor, referred to as NMDA, at an allosteric modulating site. So on the left, we see histamine binding to H1 and H2 receptors, which are postsynaptic, or binding to the H3 autoreceptor, or at the glutamate neuron, binding to an allosteric modulating site, which is NMDA receptor. So when histamine binds to postsynaptic histamine 1 receptors, in the process it activates a G protein linked second messenger system. Okay, so there's your G protein, second messenger system. That activates phosphatidylinositol and a transcription factor called CFOS. This results in alertness and wakefulness. Histamine 1 antagonists prevent the activation of this second messenger system and, in turn, cause sleepiness. So there's the H1 antagonist. It's interfering with the G protein linked second messenger system and stopping the activation of CFOS, and that results in sleepiness. We also know that histamine 2 receptors are not only in the brain, but they are also in the body. So when histamine binds to a postsynaptic H2 receptor, it activates the G protein-linked second messenger system with CAMP, phosphokinase, and a gene product called CREB. The actual function of H2 receptors in the brain is not completely understood. It seems to be, it does not seem to be directly linked to the wakefulness. Now, what about the H3 autoreceptor? When histamine binds to the presynaptic H3 autoreceptor, it stops further release of histamine. There are drugs that are an antagonist of these receptors that are being developed, which would in turn just inhibit or rather increase histamine release and thereby enhancing alertness and even cognition. Okay, this is showing us the histaminergic projections from the hypothalamus. You can see it's all over the brain. Okay, so we have some slides here that you may find interesting on treating insomnia. Okay, we are going to continue now looking at insomnia treatment psychopharmacology. I'm going to stop this recording and we will start this up as part 2 of treating insomnia.